I'm Dr. Mohammed Balghaith. I'm interventional cardiologist from Riyadh National Guard Hospital, and it's a pleasure to be today with you. I will talk about transcatheter valve programs, key for success. We know that aortic stenosis is a life-threatening disease, and the progression of that disease is very rapid. By the time our patients start to be symptomatic, the survival of those patients who started to be symptomatic, it's 50% at 2 years and 20% at 5 years. Surgical intervention for severe aortic stenosis should be performed promptly once even minor symptoms started. And nowadays, we are providing for the last 12 years in the Middle East the TAVI with the surgery. TAVR is a transformative therapy for patients with a severe aortic stenosis. As the population gets older, it can be expected that the prevalence of valvular cardiac disease will also increase. And this is what we see in our elderly patients in our area. Typically, patients of advanced age have severe comorbidities. They are significantly frail, and this will make the operative intervention a high risk. The TAVR has proven to be an effective alternative therapy to surgery, not only in extending patient lifespan, but also significantly it's improving the quality of life in our patients. As you can see here, there's two ladies with the same age, but unfortunately, the frailty in that lady on the left side is very severe. It's almost the score is 7, and in the right side, she's not frail, the other lady. And this will make a lot of difference where you, when you diagnose those patients and offer them the intervention. The first TAVI was done by Ellen Kerbier, as most of us know, and it was in 2002. And since that time, the advancement of TAVI improved year by year. This is one of our starting TAVI program 11 years ago. And again, 2 different proctors. As you can see, it's a teamwork. There is too many people involved in the TAVI. How we do a pre-assessment for TAVI and choose the TAVI or TAVR patient accordingly. We started with screening them, then we screened them for coronary artery disease, and then this will affect the procedure time. When you decided with the heart team, this patient for TAVI, you have to know about his coronary artery disease. The heart valve team, this is very important team. And with the development of structural heart disease, the heart team getting more stronger and stronger in most of our hospitals. And it's mainly involved by too many people, the interventional cardiologists and the cardiac surgeons, as we can see here, the extended heart team, imaging people, and heart valve coordinator. And everyone have his own assignment and his function. And as you can see here, cardiothoracic surgeon and interventional cardiologists, they are the top people in choosing and discussing those patients. Our imaging specialist and consultant, they play a major role in those structural heart disease. The valve clinic and screening the patient, the coordinator in the clinic, again, very important people. Referring cardiologists or teams, especially when you have referral from other hospital, primary physicians, or general cardiologists, and the cardiac catheterization laboratory staff, including the nurses, technician, and radiographer. And the cornerstone of this procedure, at least in the beginning, was the anesthesia people. As we mentioned here, you can see a procedure apart from TAVI, like other structural disease, where you can see a surgeon in the cath lab, and it's not surprising anymore. There was too many programs tried to help and minimize the TAVI and make it more effective, and too many strategies made. Like this heart valve program is to make the invasive procedure minimal and make it maximally effective. And this approach was developed to improve the outcomes to maintain the patient's functional capacity, to decrease the frequency of falls, especially in the elderly people, to decrease the delirium, and to decrease the risk of infection. Elderly patients, as we know, they have low tolerance for complication and the length of hospitalization. The development of best practice of TAVR program involves several layers, which include timely assist to therapy. TAVR patients, most of them, they are elderly people and have multiple comorbidities, as we mentioned. The successful screening starts at the referral entry point according to the protocol of the hospital. And essential patient records is very important, the information of the patient. Once the patient information is received, the data will be reviewed and will be seen by most of the people in the team. And the most important is a brief summary, include the medical history and the STS score and the diagnostic finding, including cardiac CT scan for assessment. The intra-procedural efficiency, this will make the team and the cardiac center very close to each other, and it includes all the people we mentioned before. As you can see here, the American Heart Association make a very nice program for the aortic stenosis care team. As we mentioned before, some of the referral will start from the primary care physician or general cardiologist. Then the referral comes to the interventional cardiologist or to the surgeon, valve clinic, nurse practitioner, heart failure specialist if needed, and cardiac sonographer or imagers. TAVR device platforms, we have too many technologies now available, but the cornerstone started with both TAVI or TAVR technology, the Medtronic core valve, and the Edwards Sapien valve. And as we can see here, there was a lot of advancement, both in core, the first generation, moved to the Evolute R and Medtronic, and the Pro and the Pro Plus. All of those technology made our life in the cath lab easy and make less complication to the patients. And now the size of the sheet gets smaller and smaller. The Sapien Edward also, they modify their technology and they improve it. Now we have the Sapien 3, S3, and we have the S3 Ultra. This will, with the improvement in the skirt and the technology, they improved this led to improvement in the BVL and pacemaker rate, especially in the self-expandable, improve with the technology of cusp overlap and the access. The coronary arteries also improved with the commissural alignment. Those are technique we adopted in the last few years. This is the main difference between the balloon expandable on the right, Edward, and the self-expandable Medtronic on the left side. The anesthesia, as we mentioned, you have to have a very good anesthesia or cardiac anesthesia in your cardiac center, because they are very important. We started in the beginning with general anesthesia. Now we are tending to more of conscious sedation and to be less invasive than before. The invasive lines, our aim now to decrease those invasive lines and puncture site in those elderly people. Echocardiographer, as we mentioned, this is one of the cornerstone of diagnosing severity of aortic stenosis. And again, in the beginning of the programs, most of us started with the TE and the general anesthesia. Nowadays, even some of the cath lab, they are not doing echo anymore. They are doing maybe some transthoracic, and they depend on the aortogram at the end of the deployment of the valve. The post-procedure care fast track and early mobilization. It's mainly depending on the anesthesia type and the nursing, dedicated follow-up to those patients, see at the site of the puncture if there's any hematoma, and see if there's any need for a transvenous pacemaker or transjugular pacemaker. And all those will lead to faster improvement and mobilization of the patients. We know from the latest trials that the primary endpoint, especially in the partner three, the comparison between surgical or SAVR and TAVR, TAVR did very well in comparison with the SAVR, with excellent p-value and less death, less stroke, and less rehospitalization. In conclusion, TAVI should soon become the first option and almost there for the majority of our patients, including those at low risk for surgery. SAVR will remain the best option for patients who are not optimal candidate for TAVI, and for the youngest patient, for example, with bicuspid aortic valve. Age will become a key factor in the therapeutic decision, and nowadays, if we go with the American guidelines, 65 and above, they are going for the TAVI, especially if they have comorbidity, and the STS score is a little bit high or moderate. In the low-risk population, informing the patient and the relatives about the two options will be essential in the heart team decision. Thank you very much.